The most important thing initially in using the powertome is to make sure that the tip of the instrument is actually in the periodontal ligament space. Because of that, when you start using the instrument, you want to start off with a full thickness flap and be able to visualize the crestal bone and the periodontal ligament, the beginning of the periodontal ligament space. After you gain more experience, you'll be able to get into the periodontal ligament space without reflecting a flap, which is mostly what I do now. But once you've reflected a flap, you either want to go on to one of the buccal line angles or facial line angles, whether it's the mesial buccal, distal buccal line angle. That's where the bone's a little bit thicker. You're not going to have a tendency to fenestrate the bone on the buccal, and the bone tends to be a little bit softer there. So initially, I'm going to the distal buccal line angle area of this tooth, and I'm applying power, and the tip of the instrument goes right into that periodontal ligament space. Then I'd go over to the other side here, on the mesial facial, and just keep the tip moving. That's the important thing. Those sweeping motions are very important. And then wiggling it on the way out. Notice I'm not applying power as I'm removing it, because the powertome itself only applies force, pushing in, not pulling out. Now once the line angle areas have been freed up, I go into the interproximal more so, back and forth on the interproximal, just get that as freed up as possible. You can see how loose this is getting, and it's pretty true to life at what actually happens. To get the facial freed up, you go to the in this case the distal buccal line angle. Go there, and then just start bigger sweeping motions up to the facial, and you basically will move the tip of the instrument up to the facial area. And that bone, as you know, can be very very thin, even paper thin, and you should be able to get the tooth out without perforating that buccal bone, which is critical for bone-sparing extractions. Now at this stage, I would go ahead and actually remove the tooth with forceps, and basically it lifts out. So the tip of the instrument too, you really need to know, especially of course in premolar molar areas, where exactly the mental foramen is. And how close the inferior alveolar nerve is to the teeth sockets or the tooth sockets. Don't want to perforate through the socket or leave the confines of the socket and potentially damage the nerve. And generally, you can just tell by how deep you're going whether or not you're in the confines of the socket. That really kind of covers everything. I want to go ahead and we'll take out another tooth on this side. Just to illustrate another thing, where in the maxilla, of course, you're not going to have to support the patient, but in the mandible, when you're using the powertome, you want your hand or your assistant's hand directly under the tooth you're working on. You don't want your hand over here if you're working on a lower left tooth. But I'm going to come up on the on this canine tooth here, and I'll start off on the mesial facial here and applying power. Now sometimes you'll notice what'll happen is you'll end up having the powertome angled away, and you won't be getting much traction. What you want to do is you really want to increase that angle and be straight parallel with the periodontal ligament space. And again, notice how I'm applying pressure or applying power and keep that sweeping motion going. And I'm going to come out. So what you'll notice, what will happen is you'll be going like this and the tip's not advancing. Well, if you just stand it straight up and then start your sweeping motion like this, little by little the socket's going to expand. But as soon as you increase that angle, you're less efficient. More efficient, less efficient. You can even tell the difference in the noise. So just keep sweeping back and forth, and I'm on the distal buccal line angle of the canine there. And this model is very, very close to what an actual patient, it feels like on an actual patient. So I'm going to come up here on the mesial facial here, fairly steep angle, start sweeping over to the facial now, and little by little we're going to loosen this up. I'm going to go on the distal here, again supporting underneath the jaw. There are times when you can adjust, and again you have a lot more leeway when you actually do a full thickness flap. Now that's just buried on the facial there, and that's really good. That goes a long ways to loosening up the tooth. You can come more into the interproximal area as well, you know, just depending on your access. Generally, I don't do as much work on the lingual, just because the bone's so much denser there. And generally, once you get 3 of the surfaces, the mesial, buccal, and distal surfaces freed up, the tooth's pretty close to ready to come out. So then I'm just going to apply the forceps to the tooth and just really just basically right and left rotation to the buccal, and the tooth just loosens up and comes out. And again, this is pretty true to form as to what it looks like in the mouth and what it feels like. So I think those points will be helpful for you.